So we have 2 minutes time. Anybody from the students wants to ask any question regarding last lecture or want to say anything regarding EndoRepro module, please go ahead. I think you can unmute yourself and talk to me directly. Ras, they have an access of unmuting.
Yes, doctor, they can unmute themselves. So I don't think anyone has any question regarding the last
Okay,
lecture, doctor.
okay, okay. So we have only 38 participants till now, 40. I'll still wait for 2-3 minutes and then I'll start. So I'm starting my lecture because after this we have a clinical lecture of Dr. Mona and I don't want her to wait, right? So today's topic is vulvovaginal discharge. Uh, it's a different topic, not like yesterday. Uh, it's just we are discussing about the different diseases directly. So the first one is Bartholin cyst. Bartholin glands, you must be knowing that these glands are present in either side of the vulva, and the function of these glands are to lubricate vagina. Sometimes what happens that there is inflammation occurs in these glands, and they form a cyst. So it occurs in all the ages, especially the young people, and even in the late ages also. But usually it occurs between the age of 30 to 50 because it's active reproductive ages, and it is usually 3 to 5 centimeter in diameter. It results from inflammation or obstruction of the Bartholin gland. So once there is inflammation, if the obstruction is not there, so there is inflamed area. But if obstruction goes on, what will happen? An abscess is formed. And you know what is abscess? I taught you in POD. Abscess is a collection of pus in one cavity. So they form a cyst. And this abscess is really, it's a collection of neutrophils. And it's very painful, right? So either uh, this abscess has to be drained. That's why it's very painful and it causes local discomfort. So usually antibiotics are given to treat these type of cysts. And is abscess if abscess is there and the treatment is not working properly, then surgical removal is a curative one. When local procedure are inadequate or often they are also often recurrent. So once you have treated, probably it will reoccur after 3 to 4 years, and then the same thing will goes on. And the good thing regarding this Bartholin cyst is they never become malignant. So the other condition is non-neoplastic epithelial disorders, and we have two. categories of this non-plastic epithelial disorders of unknown etiology are classified into two categories. One is lichen sclerosis, which is called atrophic skin. There is extensive area of fibrosis beneath the epidermis, so they become little stiff and also inflammation. And the other one is squamous cell hyperplasia, and this squamous cell hyperplasia is also known as this condition is also known as lichen simplex chronicus. The difference between these two we'll see, but just to discuss, in lichen sclerosis the epidermis become very thin, and squamous cell hyperplasia the epidermis become very thick. So this is a main difference between these two conditions. So just try to understand that we are dealing with which condition. Okay. Now, starting with the lichen sclerosis, it occurs commonly in post-menopausal women, means after the age of 55 to 60, and the pathogenesis is uncertain, but the presence of activated T lymphocyte in the epithelial, subepithelial inflammatory infiltrate suggests that it's an autoimmune reaction may be involved. So there is a thinning of the epidermis and a disappearance of the retipeg. I'm sure you must be knowing about retipeg, what is retipegs, or I'll show you when I'll be showing you the diagram. And there is a hydropic degeneration in the basal cells. Superficial hyperkeratosis and dermal fibrosis is also seen. There is scanty perivascular mononuclear inflammatory cell infiltrate. Mononuclear means lymphocyte, and they are mostly T lymphocyte, as I have already mentioned. The lesion appears clinically smooth and as a white patch or plaque. The labia becomes somewhat atrophic and stiffened because of the fibrosis, as I have mentioned, and the vaginal orifice is constricted. So this is a peculiar condition in this lichen sclerosis, that there is not only atrophy but stiffened labia, and the orifice become constricted. This is not a pre-malignant condition, but have increased chance of developing squamous cell carcinoma. So in a later part, when we will be discussing squamous cell carcinomas, it will also be there. So this is a histological picture of lichen sclerosis. And let me on the pointer first. So you can see this pointer. So this is epidermis. And if you see this epidermis is very thinned out, right? And this is hyperkeratosis. The keratin material is a little bit more. There is extensive area of fibrosis here. So, and there is infiltration of lymphocyte here, right? Let me draw with the pen so that you will be able to see. I think dark green color will be good for you. So this is a epidermis here, and this is thinned out, and this is hyperkeratosis, this area. Okay, and if you see here, usually in the skin you see retipex like this, but there is no retipeg here. There is just a straight line from here to here without having this retipeg. So this is a peculiar finding of this sclerosis, lichen sclerosis, because there is no retipeg, the epidermis is thinned out, there is hyperkeratosis, there is extensive area of fibrosis here, and then finally there is a lot of lymphocyte down in the dermis. And these lymphocyte are mostly T lymphocyte. Uh, you can think that how we can say this is B lymphocyte or T lymphocyte. So we have immunohistochemical stain for both of them. So we do it on this section, and then we can confidently say that these are B lymphocyte or they are C lymphocyte, T lymphocyte. Okay. So this was all about lichen sclerosis. Any question regarding this one? No. Okay. Yes. Anybody? No. Okay. Now the other one is squamous cell hyperplasia. This is another condition. It is also non-neoplastic condition, also known as lichen simplex chronicus. It appears clinically as an area of leukoplakia. So the white patches will be seen with the naked eye. A result from rubbing and scratching of the skin to relieve pruritus. So in this condition, there is there is extensive itching on that part. So when they scratch, they can help in doing the hyperplastic activity of this squamous epithelium. It is marked by epithelial thickening. Now it is just a reverse of the previous one, lichen sclerosis. It is epithelial thickening, expansion of stratum granulosum. So there is a big area of stratum granulosum and a significant surface hyperkeratosis. Although hyperkeratosis was there also, but in this case, the hyperkeratosis is more extensive. The epithelium may show increased mitotic activity in both stratum basilis and spinosum. I will show you in the picture. And the leukocytic infiltration in the dermis. So both of them can have leukocytic, means lymphocytes, and hyperplastic epithelial change show no atypia. So no atypia means no malignancy, no change into malignant one. There is no increased predisposition to cancer up till now, but it is often present in the margin of the cancer of the vulva. So this is supposed to be, they supposed, not, it is not sure, but whenever there is a squamous cell carcinoma, squamous cell hyperplasias lesion are also been seen. So they think that probably squamous cell hyperplasia is one of the causes of becoming malignant, because usually it happens after 20 to 30 years after developing this. So this is a grass picture of this, and you can see the white patch. Can you see the colors, please? So you see the marking. So this is the gross picture of vulva, and you can see the whitish patches over it. And on the right side, this is a histological picture, and this is hyperkeratosis. You see how much thick keratin is there, right? Hyperkeratosis. Here you can see retipex, which was absent in lichen sclerosis. So these are the retipex, which are normally seen in all the skin lesion, and also it is seen here also. So it is normally present. So we have that. There is some of the mitosis, for example, this one, this one. It is seen, and this is if you recall the layers of the skin. This one is called basilis, stratum basilis. This one. This is spinosum. This one. This is stratum granulosum, and there is, you see how much thick this become. Then this is lucidum, and this is corneum. So these are the layers of the skin. So now you can easily think and differentiate this from the other one. The other one was the epidermis was very thin, and here it is more hyperplastic. There are many layers of squamous epithelium. There is thick hyperkeratosis here. There is retipex present, which was absent in the other one. And in the dermal area, you can see a lot of lymphocytes. Okay, so this is lichen simplex chronicus. Although it is supposed to be a non-malignant condition, and but they have seen in a vicinity of the neoplastic lesion. We will be discussing it later. Now comes condyloma acuminatum. So they are sexually transmitted disease. It's a benign lesion and have a verrucous gross appearance. So verrucous means uh, fungating type or tree-like structure going out. Verrucous one. They may involve vulva, perineal or perianal region as well as vagina and less commonly cervix. So mostly it is present on the outer portion of the that area. They consist of a branching tree-like core of stroma covered by squamous epithelium with the characteristic viral cytopathic change is referred to as chylomicrotic atypia. So chylomicrotic atypia is the most important uh, diagnostic point of viral infection. So if you see chylomicrotic atypia, you must keep this thing in mind that you are dealing with the viral lesions. They are caused by low oncogenic risk HPV virus, which is type 6 and 11. Remember, type 6 and type 11. These viruses, HPV viruses, they are not malignant one. So they are called low oncogenic risk factors. So they cause benign lesions and represent reproductive productive viral infection in which HPV replicates in the squamous epithelium. So when this HPV enter into this squamous epithelium and replicate, they give a peculiar picture of chylomicrotic change, which is a clear hollow around the nucleus. I'll show you how it looks like. Resulting in chylomicrotic atypia characterized by nuclear enlargement, atypia, and cytoplasmic perinuclear hollow. So because it is not, although it's a benign lesion, but somewhat, a risk factor is there. So the nucleus is not appears as a normal one. Normal nucleus is a round, small nuclei, but it is little bit irregular. I'll show you. There is no association with precancerous lesion. Because of the type 6 and 11, it is supposed to be a non-malignant one. So if you see here, this is called a verrucous change. So this is vulva, and you can see a tree-like structure coming out of the vulva and a branching thing, right? It is covered with the squamous epithelium. And if you see here in the histological picture, you know how much hyperkeratosis is there, right? Thick squamous epithelium. And this is called chylomicrotic change, this one. Nucleus, around the nucleus, there is a clear hollow. And if you see beneath this one, this picture, this is a high power of the same thing. And these are a perinuclear hollow. And you can see there are two nuclei, irregular nuclei, elongated, you know. So this is called atypia of the nucleus because normally the nucleus is rounded in shape, right? But if there is some change in the uh, architecture of the nucleus, we call it nuclear atypia. Although this is not a malignant condition, that's the reason we don't see any hyperchromasia or mitotic figure here. But you can see two nuclei, three nuclei are irregular shaped nuclei. And around the nuclei, you see a perinuclear hollow here. So this is all called chylomicrotic change, which is because of the viral inclusion in these squamous epithelium. Clear? Now, remember my yesterday lecture, I said that, normally this squamous epithelium is so strong and hard, it does not allow HPV to enter. So the question arises, and I showed you the cervical cervix, the ectocervix there, in which it was covered by squamous epithelium, and there is a metaplastic one because the endocervical thing changed into the metaplastic squamous. That was the area in which HPV can easily enter. Here, it is all squamous epithelium. There is no metaplastic change. So what happens during multiple sexual activity? Sometime what happened, there is ulceration or turning of the skin, right? Surface epithelium. And that is actual place where the HPV enter into that area. Clear? Otherwise, it can never enter into this squamous epithelium. It's so strong. Okay. Now we are coming to the vulvar intraepithelial neoplasm and vulvar carcinoma. Approximately, it is 1/8 of the cervical cancer, and it is 3% of all genital cancer in female. Approximately two-thirds occurs in a female older than 60 years of age. So usually these are the tumors of the later age. It does not develop in early ages. So squamous cell carcinoma is most common histological type of vulvar carcinoma and are divided into two main groups. It's very important. Number one is basaloid or warty carcinomas related to HPV, which is 30%. And the other one is keratinizing squamous cell carcinoma not related to HPV, which is 70%. Right? So basaloid warty carcinoma, which is related to HPV, and keratinizing squamous cell carcinoma, which is not related to HPV, which is 70%. Okay, starting with the invasive basaloid and warty carcinomas, they develop from the precancerous in situ lesion called classic vulvar intraepithelial neoplasm. Formerly, it was called Bowen's disease. So when we were student, we call this lesion as a Bowen's disease. So in Bowen's disease, we call it because it has been affected by HPV virus. And in this one, the HPV virus is not 6 and 11 type. In this one, it is 16, 18, or 31. These viruses are high risk factor oncogenic viruses, right? It is characterized by nuclear ATP of this squamous epithelium, increased mitosis, and lack of cellular maturation. So it occurs in a reproductive age woman, and the risk factors are the same as those of associated with cervical squamous intraepithelial lesion. So when Dr. Imad will take this lecture, cervical intraepithelial lesions, the risk factor in cervical squamous intraepithelial lesion is young age at first intercourse, multiple sexual partner, and a male partner with multiple sexual partner. What does this mean? Means although a female has one sexual partner, that is that male, but that sexual male have different sexual female partners. So he may adopt or carry HPV virus from any of the female and infect the his own partner. So um, uh, because of it's a sexually transmitted disease, so you can spread this disease like that. So this is when vulvar intraepithelial neoplasm. Uh, why we call it VIN? Because it's a carcinoma in situ. And this is a gross picture of this, and you can see a white patch around the vulva. And if you see this logical picture, the basement membrane is totally intact. The basement membrane is intact. You can see chyliocytic changes in the cells. This is chyliocytic changes. And there is full thickness cellular atypia. And in high power, you can also see that the lining, the basement membrane is intact. So the tumor is only confined to the upper part of the epidermis, but full thickness. So if it is full thickness, then you call it carcinoma in situ. So if you go through, I think in your last case of PBL, the patient was asked for cytological examination, and when the cytology was done, it shows high grade squamous intraepithelial lesion. So this is what we have, high grade squamous intraepithelial lesion. So it is CIN 1, 2, 3 in 1. It is less than 1/3 in 2, 2/3, and in CIN 3 are carcinoma in situ. It is full thickness atypia of this squamous epithelium, which is called carcinoma in situ. Right. So this is carcinoma in situ or vulvar intraepithelial neoplasm. We call it intraepithelium because it is not crossing the basement membrane and it is not going down. Now, this is the initial part. Now, what happens? 10 to 30% of the patient with VIN also have vaginal and cervical HPV related lesion. So because this patient has already been infected with HPV, so he or she, sorry, she can have either vaginal tumor or a cervical tumor because of this HPV. The majority of the cases are positive with HPV 16. As I mentioned, these are high risk HPV type, and 18 or in 31 also. So it could be anyone, HPV 16, 18, or 31. Mostly these two are seen most commonly. There is a discrete white hyperkeratotic pigmented slightly raised lesions. Coexisting carcinoma may be exophatic or with ulceration. So we will see in this one later on. So the histologically basaloid carcinoma show an infiltrating tumor characterized by nest and cord of small, tightly packed malignant squamous cells from the basal layer of the normal epithelium and prominent collocytic atypia. So when you see the picture, you can appreciate that these are the blue color basaloid cell. These are all blue color basaloid cell. The basement membrane is torn down. The tumor cell is going down. For example, one nest is here, the other nest is here, the third nest is here. So it is infiltrating deep into the tissue. In the surface, you can see this area of necrosis. And these blue cells have a very scanty cytoplasm because they are arising from the basal cell of the skin. And you know what's the basal cell? The first layer with the dermis, attached with the dermis, the stratum basalis. It is usually blue in color. So when the tumor arises from these cells, they are called basaloid carcinoma. This is Vati carcinoma. They doesn't arise from the basaloid one. They are more mature as compared to the basaloid one. They start developing from the mature squamous epithelium, and they have a tree-like structure. Again, if you see down, the basement membrane is torn down. There is no basement membrane, and the tumor cells are going down, and they are forming nest and sheet of squamous epithelium. And you can see hyperchromatic nuclei, pleomorphism, hyperchromasia, and these cells are also showing chylostic change, which shows that you are dealing with the HPV virus. So this you have a well-formed chylosite even in the basaloid type. You can see even the coalocytic areas, right? And these are epithelial pearl, this one. These are basically a keratin which is deposited in the center of the nest, which is called epithelial pearl. So this is one of the diagnostic feature of squamous cell carcinoma. The other one is keratinizing squamous cell carcinoma. The keratinizing squamous cell carcinoma, they are non-HPV related. So there is no HPV involved. This is 70% of the other side. They arise in the individual with long-standing lichen sclerosis and squamous cell hyperplasia. So lichen sclerosis, which have already discussed, having a thin epidermis without retipex, and a squamous cell hyperplasia, thick skin with the retipex and uh, a large area of hyperkeratosis with a mean age of 76. So usually, as I said, that lichen sclerosis and hyperplasia usually develop at the age of 45, 50. It takes another 20 years or 25 years to develop squamous cell carcinoma. The pre-malignant lesion referred to as differentiated vulvar intraepithelial neoplasm or differentiated VIN or VIN simplex. Right. So these are the name given. Why? Because the basement membrane of this tumor is intact. So they are called in situ carcinoma, differentiated intraepithelial neoplasm or vulvar intraepithelial VIN. So differentiated VIN characterized by atypia of the basal layer with the normal epithelial maturation and differentiation into the superficial layer. So you can easily identify that we are dealing with this squamous epithelium. The etiology of differentiated VIN is unknown, but it is associated with chronic irritation in lichen sclerosis and squamous cell squamous cell hyperplasia. So as I said, that they are seen in the vicinity of the tumor, and they think probably the squamous cell carcinoma is arising from this area. So probably they have some association with that. So this is a picture of differentiated VIN. So when it is VIN, the basement membrane is intact. Right? If you go down, probably you will be seeing that the basement membrane is intact and the tumor is not going down. It is only limited to the superficial area, and you can easily appreciate that you are looking at squamous epithelium, so that is differentiated. It's not undifferentiated one. And you can see nuclear atypia, hyperchromasia, and all the feature of malignancy you can see. You can see also the mitotic figures. Okay, so this is differentiated VIN, and it is negative for HPV. Now, the malignant part of this one is a carcinoma associated with lichen sclerosis, squamous cell carcinoma, and differentiated VIN, which we have already seen, appears as a nodule. The cancer may be misinterpreted as a dermatitis initially, because the female is suffering from a lichen sclerosis or squamous hyperplasia. So when it becomes malignant, still the patient think that, or the doctor think that it is just because of dermatitis or eczema or leukoplegia for a long period, because usually it occurs after 25 to 30 years. So usually the patient is taking treatment for that. So the clinician think that it's still this inflammation is going on, but unfortunately it has been converted into a malignant one. So clinical manifestation include local discomfort, itching, and exudation because of the superficial secondary infection. So because of the infection, the thing become deteriorated. Histologically, reveal infiltration or infiltrating tumor characterized by nest and tongues of malignant squamous epithelium with prominent central keratin pearls. So whenever you deal with this squamous epithelium, you will see a keratin pearl. So this is a gross picture, and you can see that it's a fungating out of the vulva, and this is all white patches which you can see, and you can see some necrotic ulcerative area also. And here this is a low picture of the same thing, and you can see tree like verrucous lesion here, and this is all squamous epithelium. And here you can see that the basement membrane is torn and the malignant cell is going deep, right? And these are epithelial pearls. In the center of the nest, you see a keratin deposited in between. Why keratin? Why? Anybody? Anybody from the class?
Because it's a squamous cell carcinoma and they're known to produce keratin pearls.
Very nice. Excellent. Very nice. I'm really happy that you are with me in my lecture. I am not discussing alone. So because these are squamous epithelium, and the squamous epithelium usually secrete keratin. They make keratin and they push keratin out, and they make a layer of keratin above this squamous epithelium. For example, if you talk about the skin, this keratin layer is a protective layer, and it helps the viruses or bacteria or anything should not enter in our body. So they are secreting keratin. So when it becomes malignant, definitely they are producing keratin and deposit here. Remember one thing, you see this thing in well differentiated and moderately differentiated squamous cell carcinoma, but in poorly differentiated carcinoma you hardly see any keratin pearl. So it is really difficult to see that, right? Okay. Now glandular neoplastic lesions. So we have there is a gland, like a breast. The vulva contain modified apocrine gland. So the vulva may contain tissue closely resemble breasts, so they are also called ectopic breasts. So exactly the same uh, uh, glands which are seen in the breast, this apocrine sweat gland, are seen in vulva. Develop two tumor with the counterpart in the breast, like number one is papillary hydrangeadenoma and the other one is extramammary Paget's disease. So we will discuss one by one. First, papillary hydrangioma, present as a sharply circumscribed nodule, most commonly on the labia majora or interlabial fold. The histology of the hydrangioma is identical in the appearance to intraductal papilloma of the breast. So when Dr. Imad will be teaching you the breast in benign lesion, he will teach you intraductal papilloma. So this head adenoma is exactly the same one of the breast and consists of papillary projection covered by two layers. And this is a pathognomonic point of papillary carcinoma. Number one, the top is columnar cells, secretory cells, and an underlying layer of flattened myopathy cells. So there are two layer of cells. The above one is the squamous epithelial cell, and below one is the myoepithelial cells. And these myoepithelial cell elements are characteristic of a sweat gland and sweat gland tube. So if you see here, this is the lining epithelium of the vulva. So it is a stratified squamous epithelium. Beneath this is a glandular one. And if you see, there is a papillary projections. So this is one papillary projection. This is another papillary projection. This is another papillary projection. And if you see it closely, you can see the outer one. This one is a columnar epithelium. This one, columnar epithelium. And the below one is a myoepithelium. This one. So the above it is columnar. Below it is myoepithelium. So if I draw here, it will look, let me change the color. If I draw here, it would look like this. This is columnar epithelium. And beneath this is the myoepithelium. Myoepithelium is basically a flat type of epithelium, but it is always double lined. So we have nuclei here, squamous epithelium, which is basally placed. So if you see, you will be seeing these basally placed nuclei. They are a little bit elongated. So we'll make it elongated. Okay. And the myoepithelium is a layer beneath the columnar epithelium. Okay. So this is a pathognomonic point of this one. Now coming to the extramammary Paget's disease, a rare lesion of the vulva, and sometimes perianal region is similar to a Paget's disease of the breast. That's why we call it extramammary Paget's disease, because the feature, a histological picture is just identical to that one of Paget's disease of the breast. It present as a pruritic red crusted sharply demarcated map-like lesion occurring usually on the labia majora, again in the vulva. It may be accompanied by palpable submucosal thickening of the nodule. Paget's disease is a distinctive intraepithelial proliferation of the malignant cell. So this is a malignant one. That one was a benign one. Papillary hydrangioma was a benign lesion. This is a malignant one. The macroscopic appearance of a large tumor cell lying singly or a small cluster within the epidermis and its appendages. These cells are distinguished by a clear separation hollow, which is really important, with the surrounding epithelial cells. Finally, a granular cytoplasm containing mucopolysaccharide, which will be stained with either PS stain, periodic acid shift stain, Asian blue, or VC carbon. So in this is actually my case. I had presented. If you go and see in the journal, you just write extra memory package. This is Dr. Brar. I didn't write this one, but these are my pictures. I have taken it, and it was published. So this is, if you see, these are all vegetoid cells. So these are either individual cells or they are arranged in a nests, but it is present in the basal area, right? So these are all vegetoid cells. These cells are having large hyperchromatic polymorphic nuclei and a clear hollow around the nucleus. So this is a peculiarity of the Paget's disease, right? So if you see the caption, it's a sheet and cluster of large a neoplastic cell with a clear cytoplasm. And the nuclei are hyperchromatic and pleomorphic and a probity nuclei. And the tumor cells are causing parabasal clefting or acanthosis. So this is called parabasal clefting and acanthosis. Means uh, it's a breaking of the epithelial layer above that, acanthosis. Now this is Elchen blue stain, and you see these cells are stained blue with Elchen blue staining. This is a diagnostic feature, one more. And other feature is if you do cytokeratin scan, cytokeratin stain, because this picture or this histological picture is more close to melanoma, because melanoma also look like the same. So you have to differentiate extramemory Paget's disease with the melanoma one. So in extramemory Paget's disease, they are positive with CK7. So this is actually immunohistochemical stain, CK7, which show positivity of these cells. But when we performed S100 and HMB45, those were negative. So this is a diagnostic feature of extramemory Paget's disease, that they are positive for CK7, but they are negative for S100 and HMB45. Now coming to melanomas, less than 5% of all vulvar carcinoma and 2% of all melanoma in women. Their peak incidence is in a 60th and 70th decade. So usually it occurs in a very late life. They tend to have a same biological and histological characteristic as melanoma elsewhere in the skin. So either it is in the vulva, either in a hand or in the back, wherever it is, histological picture will be absolutely same. 5-year survival rate is less than 32%. So this is highly malignant tumor and melanomas especially. The prognosis is linked principally to the depth of invasion, with the greater than 60% mortality for the lesion deeper than 1 millimeter. So just imagine 1 millimeter mortality rate 60%, 5-year survival. So if it is 2 mm, it becomes half, only 30%. If it is 3 mm, hardly 10%. So you just imagine how, and this is called Croc's levels, and we do it histologically. I'm not going in detail. So in immunohistochemistry, reactivity of antibody to S100, HMB45, and it will be negative for cytokeratin 7. So as in the previous one, in extramemory Paget's disease, it was positive in CK7, but it was negative for HMB45 and S100. In this case, it is positive in S100 and HMB45, and it is negative for CK7. So this is a very important diagnostic feature of that. So if you see this one, this is a gross picture of the melanoma of the vulva they have taken out, and you can see a black coloration of, it's a malignant counterpart of nevus, a mole. If it is present in the face, it looks very beautiful, but if it turns malignant, it is one of the most dangerous tumors you can ever have. So if you see histological picture, these are all malignant melanocytes. So this one, they also show a perinuclear hollow, just like in a Paget's disease. So they are also, you can form a sheets and groups. So by looking at this one, and if you go back and see that picture, it looks probably the same. But to differentiate, we have performed S100 and HMB45, and it is positive for S100 and HMB45 here, and it is negative for CK7. Okay. Now coming to vaginal adenosis and clear cell carcinoma. Hopefully, inshallah, you have no problem up till now my lecture. If you have any problem after the lecture, I'll ask you and we'll go back and open that slide. Don't worry. Vaginal adenosis and clear cell carcinoma. Adenosis normally present in a small percentage of adult women exposed to diethyl stilbestrol or DES. What is this one? Diethyl DES or stilbestrol is a synthetic form of hormone estrogen that was prescribed to pregnant women between 1940 and 1971 to prevent miscarriage and premature labor. So, this was given to the female to prevent premature labor. What happens? A rare cases of clear cell carcinoma arising in DES related adenosis were recorded in teens and young women in 1970s and 80s. So what happens that when this given to the mother, the babies which are born and they become adult, they have seen that either these female develops adenosis or they develop clear cell carcinomas in a later age. So this is a normal looking cervix, very shining squamous epithelium, right? And you can see even the endocervical area here. Here, this is adenosis. What happens that if you see this histological picture, these are the glands which are, proliferating down. Normally, it's not present in the cervix, but in some of the cases, it pushed up this gland, and they go up, and they also involve the squamous epithelium area. So because it has ulcerated the squamous epithelium, so it looks like granular areas here. It is not like so shiny as it should be normal looking squamous epithelium, but it appears as granular. Why? Because these gland goes up and they do the ulceration of the squamous epithelium. So if you do the coldoscopic examination, you see a reddish like picture like this, not a clear shining squamous epithelium. So this is adenosis, and this is seen on the babies of the patient who had received DES, right? Just remember this thing. And this is clear cell carcinoma. This is also clear cell adenocarcinoma of the vulva and vagina, and also seen in those patients who had taken DES. So these are hyperchromatic nuclei and clear cytoplasm. This is a peculiar diagnostic feature of clear cell carcinoma. So if you see this type of picture in vulva and vagina of that area, then if you ask, because nowadays DES is no more given to the females, so this tumor is hardly seen nowadays. So it's a matter of old ages, but we have to teach you about this one. Okay, so this is mitotic figure. This is another mitotic figure, and these are clear areas, clear cells carcinoma. Now, the last tumor which we are discussing now is embryonal rhabdomyosarcoma. Embryonal, the name says we are talking about a primitive one, embryonal one, small children. Rhabdomyosarcoma, malignant tumor of the skeletal muscle. Okay. Also called sarcoma vitroides. Why? Because it's a grape-like one, found in infants and in children younger than 5 years of age, and consists of predominantly of malignant embryonal rhabdomyoblast. So this is a diagnostic picture of that one. They have appearance of the and consistency of grape-like clusters. So they are called vitroides, means grape-like. They tend to grow as a polypoid around bulky masses that sometimes fill the and project out of the vagina. So it's a grape-like one. Histologically, the tumor cells are small and have a oval nuclei because it's and this tumor comes under the heading of small round blue cell tumor. So we have a distinct tumor under the heading of small round blue cell tumor, and this is one of that, right? So they have oval nuclei with small protrusion of the cytoplasm. So the cytoplasm is bit spindly here, and from one end resembling a tennis racket. So or you can call as a hand mirror. So in hand mirror you have it appears like this one, like this. So this is mirror. So this nucleus, and this is cytoplasm. So it looks like a hand mirror appearance of the cells. And sometimes you can even see striation, which is commonly seen in the striated muscles. Beneath the vaginal epithelium, the tumor cells are crowded in so-called cambium layer. So uh, usually it is very shallow or less amount of tumor cell, but at the margin or at the under the epithelium, these malignant cell they goes together and form a cambium layer, which I'll show you in the slide. For this reason, the lesion can be mistaken for a benign inflammatory polyp. So because down it's very shallow and only they are condensing on the surface, so they are sometimes misdiagnosed as a polyp, inflammatory polyp. These tumors tend to invade locally and cause death by penetrating into the peritoneal cavity and obstruction of the urinary tract. The conservative surgery coupled by chemotherapy seems to offer a best result in cases diagnosed sufficiently early. But usually, as I said, it looks like a polyp. So, diagnosis usually take longer time. So this is the vagina, and you can see that this tumor is actually coming out, and these are the grape-like structures. So and that's why it's called sarcoma botryoides. And if you see this logical picture, this is squamous epithelial lining of the vulva or vagina here. This is squamous epithelium, and this is a cambium layer. So these cells densely populated just beneath the epidermis. So this is called a cambium layer. If you go through in a high power, you can see that these cells have the same feature. So if you go down, they are not gathered together. Uh, they are scanty, scattered cells. So if you see and if you overlook it, you can see and you can think that probably these are all lymphocytes. So usually it happens because when I was doing my residency, a such case uh, came in front of us, and we were also in a puzzle that is it an inflammatory polyp or something else. So for us, inshallah, because we had a provision of doing immunohistochemical stain, so we performed MyoD1, and it turns to be strongly positive in this case. So we labeled this case as a sarcoma botryoides. So this is how you differentiate between the tumors. So this was all about today's lecture. So if you have any question, please kindly ask so that I can go back. You have 5 minutes time to ask question, because then Dr. Mona is going to take the lecture. Any question?
Doctor,
Yes.
I didn't really understand slide 31, the two gross pictures. Are they both abnormal or like
Which one?
the one in the cervical glands?
Just tell me, huh? Which one?
Go up, yes, yes. Up. Yes, this one. The two gross pictures. Oh, good.
Yeah, this one. No.
No, the one down, doctor. Two
Yeah.
slides down. No, doctor. Slide 31, the two cervical
I
gland.
cannot see the number here, right? So you have to tell me.
Yeah, down,
Vaginal
doctor. No.
adenosis.
Yeah, the vaginal adenosis.
Adenosis. Okay. Adenosis. Here. This one, right?
Yeah, are
So
these
what
two
is?
both abnormal or like the
No.
gross picture?
The gross picture of this one is normal. It's a normal looking squamous epithelium. I have kept this picture to compare this one with this thing. This is also cervix, and this is red in color. It is not shining, right? So I have placed this normal picture to just show you that in a normal cervix, it looks like this one, right? And this is an abnormal cervix, which is red in color, granular, not shining. Why? Because these glands, which is adenosis, they are coming up and involving the surface. So the smooth surface of a squamous epithelium, which should be looking like this one, now it appears like this one. Is it clear now?
Yes, thank you, doctor.
Okay. Anything else? Anything else? Please come up. I'm here with you. So you have understood what I have taught, right?
Yes, thank you, Doctor.
Okay. Now I want, because you are all with me, I want the class representative to come to my office in in lunchtime. So we will discuss something because I got uh, let me see if we can decrease some of the lectures, right? Okay. Thank you.
Okay.
Thank you very much. Thank you all.